Hello, good morning, guys. This is Dr. Tahira, one of the study MEDIC-MRCOG mentor. Today, I'm going to discuss with you prenatal care module, which is we are launching in our RRR series, which is going to be in the YouTube channel and which will be help you in your upcoming EPCOG Part 1 exam. So let's talk about the prenatal care. So what is prenatal care and why it is important? Having a healthy pregnancy is one of the best ways to promote a healthy baby birth. Getting early and regular prenatal care improves the chances of a healthy pregnancy. Prenatal care can help prevent complications and inform women about important steps they can take to protect their infant and ensure a healthy pregnancy. With regular prenatal care, women can reduce the risk of pregnancy complications. So I'm going to discuss the early pregnancy complications in our prenatal care. So the topics will be cell-free fetal DNA-based non-invasive prenatal testing of aneuploidies, evaluation for screening for Down syndrome, early pregnancy problems, manual vacuum aspiration, issued a recurrent pregnancy loss guideline, medical management of miscarriage, abortion care, perforation of the uterus, ectopic pregnancy, cesarean scar ectopic pregnancy. So we will give you some overview and the basic revision points. So let's start with this scenario. A 48-year-old woman who teaches children with special needs is 12 weeks in pregnancy, into her first pregnancy, and is very anxious about the risk of Down syndrome. She wishes to have a diagnostic test, but is not ready to take the risk of miscarriage associated with invasive testing. So we have the options here: nuchal translucency screening, chorionic villus sampling, combined test, amniocentesis, quadruple test, amniotomy, triple test, cell-free fetal DNA test, amniodrainage, chordosynthesis. So our option will be cell-free fetal DNA. This hormonal or maternal serum for cell-free fetal DNA is a non-invasive test for testing fetal aneuploidies in maternal blood after 10 plus weeks gestation. Non-invasive prenatal test using cell-free fetal DNA to test for the aneuploidies. NIPT is a screening test and needs confirmatory invasive testing in case of a high-risk positive results. The sensitivity of screening for trisomy 21 is 99.9% in cell-free fetal DNA. So let's talk about some bases of the cell-free fetal DNA. It comprises small fragments of fetal DNA thought to originate from the trophoblast. These fragments circulate in maternal plasma and form approximately 10% of the DNA fragments in maternal plasma. It is present in reliably measurable levels for aneuploidy screening from 10 weeks onwards of gestation and is cleared quickly from the maternal circulation hours after delivery, making it specific to that pregnancy. So let's see, it's present in the maternal blood cells, trophoblast, maternal DNA. So if we will go for the first trimester combined test, which is going to be done 11 to 13 weeks, in which comprises fetal nuchal translucency, serum beta HCG, and PAPE. So it will give you the high risk test, intermediate risk, and low risk. If low risk, we should not do anything. We have to reassure the patient. And if it is high risk, which is telling us that more than equal to 1:10 risk, then definitely we have to proceed for the invasive testing. And invasive testing, we know that it is chorionic villus sampling around after 11 to 13 weeks of gestation, and amniocentesis after 15 plus weeks of gestation. And if it is intermediate risk, then we have to proceed for the cell-free fetal DNA test. Again, if it is positive, we have to proceed for the invasive test. And if it is negative, we have not to do anything. We have to reassure the mother. Now, let's talk about the evaluation of the Down syndrome screening. So screening for fetal trisomy 21 has evolved from advanced maternal age with a detection rate of 30% alone, with a false positive rate of 5%. If we will proceed the second trimester serum biochemistry with a detection rate of the 60 to 75% and false positive rate of 5%. And if you will go for the first trimester combined screening, then it will give us the 9% deduction, 90% deduction rate with the false positive of the 5%. Let's solve this question. 35-year-old woman, she's pregnant of 16 weeks of gestation. What is the detection rate sensitive to quadruple test for Down syndrome? A is 30%, B is 70 to 75%, C is 90 to 92%, and D is 80 to 90%. So the answer is 70 to 75%. This charts will give us the exact criteria. So if we will go for the maternal age, 30% is the deduction rate. Second trimester, there are double test, triple test, and quadruple test. Double test, alpha fetoprotein and serum beta HCG. It will give you the deduction rate of 60 to 65%. And if it triple tests alpha fetoprotein, beta HCG, and estradiol, it will give you 65 to 70%. And if there is quadruple test, alpha fetoprotein, free beta HCG, estradiol, inhibin A, that give you the detection of the 70 to 75% with the false positive rate of 5%. And if we will go for the first trimester combined test, in that 90% you will detect the trisomy 21. And if it is serum free fetal DNA in the maternal plasma, then it will detect the trisomy 21, 99% with the 0.1% of the false positive rate. Let's have another question. 38-year-old woman, gravida 2 para 1 at 13 weeks of gestation, attends fetal medicine unit for counseling after the screening positive combined screening results with a risk of 1:50 Down syndrome. She is very keen to have a definitive diagnosis and opts to have invasive testing. So what are her options? Nuchal translucency scan, chorionic villus sampling, combined test, amniocentesis, quadruple test, amniotomy, triple test, cell-free fetal DNA, amnioreduction, amniodrainage, and the chordocentesis. So our option will be the chorionic villus sampling because she is 12 weeks. And CVS usually perform between 11 and 13 plus 6 weeks and involves aspiration biopsy of the placental villi. And amniocentesis, as we all know, it will be preceded after the 15 weeks of gestation and around the from the amniotic fluid around the baby. So let's talk about early pregnancy. Early pregnancy will be comprises normal cited pregnancy, ectopic pregnancy, and none not identified. So in the normal cited, we will see the early pregnancy, we will see live pregnancies, we will see the miscarriages. Regarding ectopic, it will be rudimentary horn, it will be in the extrauterine or uterine. If it is extrauterine, then it will be tubal, interstitial, isthmus, and ampullary region, ovarian or abdominal. In the uterine will be the cervical ectopic pregnancy, cesarean scar ectopic, intramural, or the cornal horn of the uterus. And non-identified, as we all know, pregnancy of unknown location. And we will talk about the partial or complete molar pregnancy too. So there are the terminologies about the threatened miscarriage, inevitable, incomplete, complete, and missed miscarriage. Threatened, as we know, it is a threat of the miscarriage that exists when unprovoked vaginal bleeding with or without over abdominal pain occurs before 22 to 24 weeks of gestation, and it will be with the viable pregnant fetus. Inevitable, deemed inevitable when specific clinical features indicate that a pregnancy is in the process of physiological expulsion from within the uterine cavity. Pregnancy will not continue and will proceed to incomplete or complete miscarriage. Incomplete when there will be the tissue partially expelled. It is possible that many incomplete miscarriages are unrecognized as a miscarriage. And complete miscarriage, the whole of the pregnancy contents will be completely expelled out. And missed miscarriage, the ultrasound features consistent with a non-viable or non-continuing pregnancy. Even in the absence of clinical features, early pregnancy tissue may be partially expelled. Missed miscarriage is usually an incidental finding because there is rarely any indication that anything was wrong with the pregnancy. Some women do recall a transient and or brownish vaginal discharge or a vague reduction in symptoms of early pregnancy. So how we have to diagnose? There are certain ultrasound criteria. If the CRL, crown rump length, is 7 millimeter above with no fetal activity, or mean gestational sac is 25 millimeter or above and is empty, so on, we have to offer transvaginal scan in 7 days, or we have to offer the woman a second opinion. There is a second option. If the mean gestational sac is less than 25 millimeter, then we have to repeat scan after a minimum of 7 days. And if the CRL is less than 7 millimeter with no fetal heart activity, we have to offer a scan after minimum of 7 days. And if you will proceeding with the transabdominal ultrasound and there is no fetal heart sounds, then we have to offer the woman rescan minimum of 14 days. So let's solve this question. A 33-year-old pregnant woman at 6 weeks gestation presented with 1 day history of heavy vaginal bleeding. Her pregnancy test was positive. Her ultrasound shows endometrial thickness of 16 millimeter. No adnexal mass. What is the likely diagnosis? We have the options: complete miscarriage, pregnancy of unknown location, ectopic pregnancy, pregnancy of unknown viability. So the answer is pregnancy of unknown location. Why? Because when a woman has a positive pregnancy test, but no intrauterine or extrauterine pregnancy can be seen with a transvaginal ultrasound, then we will label this pregnancy as pregnancy of unknown location. So how we will follow this pregnancy? We have to monitoring with the beta HCG and the scan. So if we will do the beta HCG level on day 1, we have 3 options. If it is decreasing by 50%, so it means it is a resolving pregnancy, and we have to repeat the urine pregnancy test in 2 weeks. If it is giving us negative, we have to do no action. And if it is positive, then again we have to do the reassessment. So second option, if we repeat serum beta HCG 48 hours after the first test, so if the rise between 50 and 63%, so it is inconclusive. What we have to do, we have to refer the woman to the early pregnancy unit within 24 hours. And if it is raises above 63%, so it means it is a ongoing likely pregnancy, or we have to repeat the scan if when beta HCG above 1500 international unit of per liter. So it will give us that if it is a ectopic pregnancy or it is a live pregnancy, intrauterine. So let's have a picture look. Here we can see the uterus is empty. This is the endometrium. This is the interstitial part. This is the uterine cavity with the empty endometrium. So now see, a gestational sac close to the uterus but not surrounded by myometrium. It is the ischemial tubal ectopic pregnancy. See in the B picture, gestational sac in the ischemial part, and this is the endometrial cavity which is empty. Now see again 3D mode. Endometrial cavity is empty, intrauterine cavity is empty, and this is the gestational sac in the ischemial part of the tube. So it is a ischemial tubal ectopic pregnancy. So now ultrasound criteria of the ectopic pregnancy diagnosis. So tubal inhomogeneous mass in the adnexal. This is the inhomogeneous mass. Then empty extrauterine gestation. See, endometrium is empty. Extrauterine gestational sac is there. Extrauterine gestational sac with the yolk sac and the fetal cardiac activity. That is present here. Interstitial, uterine cavity is empty. This is the interstitial products of conception locate outside of the endometrial cavity, surrounded by a continuous rim, myometer within the interstitial area. Now the cervical pregnancy. See, gestational sac in the cervical canal. Endometrial cavity is empty, and sliding sign is there. And the caesarean scar. Here is the caesarean scar. And this is the gestational sac. It is the caesarean scar ectopic pregnancy. How you have to manage the ectopic pregnancy now. So let's come. If we are suspecting the ectopic pregnancy, if the patient is hemodynamic instability, history and examination will tell us. So our concerns of significant interperitoneal bleeding, what we have to do, we have to go for the urgent surgical management, either laparoscopically or either laparotomy. Then if it is patient is stable and no concern of significant bleeding, then how we have to monitor ectopic pregnancy suspected ultrasound or serum beta HCG, significant pain, abdominal mass more than equal to 35 millimeter, fetal heartbeat present, and serum beta HCG level more than 5,000. So in this criteria, again, we have to proceed for the surgical management. We'll go for the laparoscopy or laparotomy. What are the choice? And then again, how you will proceed? Either salpingotomy, if the contralateral tube is already not there or damaged, or salpingectomy if the other tube is healthy. Then, if no significant pain, agonal mass less than 35 millimeter, no visible heartbeat, no intrauterine pregnancy. Again, you have to see for the serum beta-HCG. If it is in the range of 1500 to 5000, so plus minus either surgical or medical management, and serum fetus-HCG less than 1500, prefer medical management with the injection methotrexate to exclude the allergic to the patient. And if the serum beta-HCG less than 1000, then we have to proceed for the expected management. 60% of women will respond to the expected management too. Let's call this question now. A 35-year-old woman who has 3 previous cesarean section presents with scar pain and vaginal bleeding at 7 weeks of gestation. What is the primary diagnostic modality for diagnosing cesarean scar ectopic pregnancy? So clinical examination, CT scan, hysteroscopy, laparoscopy, laparotomy, MRI scan, no diagnostic test required, serum alpha-fetoprotein, and serum beta-HCG, serum progesterone, transabdominal ultrasound, transvaginal ultrasound, or transperineal ultrasound. So definitely we all know that the transvaginal ultrasound is the modality, primary diagnostic test to diagnose the scar ectopic pregnancy. Another question now, 20 years old woman present with a history of the vaginal bleeding and abdominal cramps at 10 weeks gestation. Her pulse is 90 beats per minute. Her blood pressure is 140 by 90 by millimeter of mercury, and ultrasound shows a snowstorm appearance with no fetal pole. What will be your diagnosis? Missed miscarriage, pregnancy of unknown location, inevitable miscarriage, and threatened miscarriage, ectopic pregnancy, molar pregnancy, complete miscarriage, septic miscarriage, recurrent miscarriage, or incomplete miscarriage. So our diagnosis will be molar pregnancy. In molar pregnancy, women tend to present with irregular vaginal bleeding during first trimester or with exaggerated pregnancy symptoms like hyperemesis, hyperthyroidism, or preeclampsia. On examination, the uterus is usually large for dates, and ultrasound features include characteristic snowstorm appearance of mixed echogenicity representing hydropic villi and intrauterine hemorrhage. So have a look now. We have this dispermic partial hydriform mole. This is the typical picture. Okay, and what is our basis of genetics? Partial moles arises at the point of the fertilization. So partial moles generally compose of the triploid conception. See, this is, and containing 69 chromosomes. When an ovum is fertilized by 2 spermatozoa, otherwise known as a dispermic or diandric monogenic partial hydriform mole. This is regarding the complete molar pregnancy, in which, see, this is the creates like appearance, and in the complete mole, diploid and androgenetic in a region containing no fetal tissue due to an absence of the maternal genetic material, and have a 46XX monospermic complete mole. 75% resulting from the fertilization of an empty ovum with a single sperm, which then duplicates its genetic material, monospermic complete mole. The genetic material in this ovum may have been lost either before or after fertilization. 25% remaining will give you here complete arise from the fertilization of an empty ovum by 2 sperms. See here. And dispermic complete mole, while very rarely complete moles occur due to the fertilization of an enucleate ovum by a diploid sperm, which has unsuccessfully undergone meiotic division. Now let's proceed with this question now. 29-year-old para woman and presents to the early pregnancy assessment unit at 8 weeks of gestation with mild vaginal bleeding. A transvaginal ultrasound scan performed by ultrasonographer reveals an absent fetal heartbeat and is reported as missed miscarriage. You are in gynecology on call, and you have been asked to review this woman and consent her for surgical evacuation of the retained products of conception. the following risks should be discussed with this woman. A, one in 1,000 women require repeat surgical evacuation. 3 in 1,000 women will have localized pelvic pain. 3 in 10 women would need blood transfusion. Bleeding following evacuation of routine products may last up to 4 weeks. Uterine perforation is uncommon but may be seen in 5 in 1,000 women. So, whenever we are going to consent, we have to discuss all options with this patient. So, the correct answer is uterine perforation is uncommon but may be seen in 5 in 1,000 women. So, risk associated with the surgical evacuation, frequent risk, bleeding lasts up to 2 weeks is very common. 1 in 2 women in 1,000 women need blood transfusion. This is uncommon. 5 in 100 women need repeat surgical evacuation. That is common. 3 in 100 women may get localized pelvic inflation. This is common. Serious risk uterine perforation is up to 5 in 1,000 women, uncommon. And severe trauma to the cervical neck, there is no evidence that this procedure would affect future fertility in these women. So these women should be informed about the available alternative treatments, which include medical management, mifepristone, prostaglandins, and expected management, particularly for women without an intact sac. They should be informed that there is a still 15 to 50% possibility eventually needing surgical evacuation for little needs or because the woman prefers to have it. Now let's talk about something, manual vacuum aspiration. Whenever there is a miscarriage or incomplete miscarriage, medical management is failing or patient is opting for surgical management, we have the option of the manual vacuum aspiration. It will be done under general anesthesia. It will be done in the local anesthesia. So what we have the prerequisite. So definitely we need the consent. It will be written and informed consent. Cut off crown run length for manual vacuum aspiration is less than 25 millimeter. Cervical priming, yes, with misoprostol 400 microgram, either giving orally, vaginally, or sublingually 2 to 3 hours before the procedure. And definitely, if it is doing under local anesthesia, needs with the naproxen, brufen, or paracetamol. Something about the ESHRI guideline of recurrent miscarriage. They are talking about the antiphospholipid syndrome, how we will treat. So for women who fulfill the laboratory criteria of the antiphospholipid syndrome and a history of 3 or more pregnancy losses, they suggest administration with low dose aspirin 5 to 80 milligram per day starting before the conception, and a prophylactic dose of heparin unfractionated or low molecular heparin starting at a date of positive pregnancy test or no treatment. We have the option now. The woman attends the miscarriage clinic after 3 consecutive miscarriages. All investigations are normal. She subsequently has a 4th miscarriage, which is managed surgically. So what is the clinical scenario? You have to choose for this patient for the further test. So dilute Russell Viper Venom test, glucose tolerance test, karyotyping of product of consumption, no test required, ovarian autoantibodies, peripheral blood karyotyping, pelvic ultrasound, peripheral blood natural killer cell testing, serum cytokine levels, thrombophilia screening, thyroid function test, thyroid peroxidate antibodies, torch screening, or uterine natural killer cells. So as we know that this patient having no any other abnormalities, so definitely we will proceed for the karyotyping of the products of consumption. Cytogenetic analysis should be performed on the products of consumption on the 3rd and the subsequent consecutive miscarriages. So let's see what the guideline of recurrent miscarriages by ESHRI is giving us the summary. So recommended test, they are telling if recurrent pregnancy loss more than equal to 2 pregnancy losses, we have to proceed for the antiphospholipid syndrome, lupus anticoagulant, or anticardiolipin antibodies. If it is positive, we have to start low dose aspirin and prophylactic dose heparin. We have to proceed for the thyroid abnormality test. And if it is positive, again, we have to start for the woman levothyroxine for the overt hypothyroidism. We will go for the investigation of the uterine anomalies by 3D ultrasound. So they are telling that effect of surgery is insufficient evidence-based. What about the genetic test that can be considered for exploratory purposes in a research context only? That is genetic testing. Genetic counseling needs to be offered to the patient and information to be given to them for the pre-genetic testing. And immunological testing, that is HLA and ANA, no specific treatment available for that. Serum DNA fragmentation test, if it is there. So we have to offer the men lifestyle modifications. Screen for hereditary thrombophilia, other immunological test, and that non-immunological test and the metabolic hormonal test, they are not recommended by the ISHRI guideline. So lifestyle modification, and we have to give the prophylactic vitamin D for these women. So thank you. These are the some points for the revision purpose. So we are launching this RR series for the students who are sitting for the upcoming EFOG Part 1 exam. Click and subscribe our YouTube channel, and believe me, these videos are very helpful for the preparation of your exams. Thank you. See you again.